Welcome to the other side of Lucy Letby. In episode 64, we're going to finish off the international panel review into the causes of death in the babies at the Countess of Chester Hospital. And straight away we go to baby 6 summary. Now baby 6 is baby F, one of the insulin cases, which I have covered in another podcast. But let's see what the panel said about baby F and compare it to what I said about baby F. Baby F was 29 weeks, born at 1.434 kilograms, second twin, borderline intrauterine growth restriction, male infant who was born by emergency cesarean section for absent end diastolic flow. So, what is absent end diastolic flow and intrauterine growth restriction? Well, intrauterine growth restriction, IUGR, simply refers to a condition where the fetus doesn't grow at the expected rate during the pregnancy. And this can be due to maternal, fetal, or placental problems, or a combination of all three. And the baby, when born, is then said to be small for gestational age, which is typically defined as birth weight below the 10th centile. That means that 90% of babies would be born heavier than an intrauterine growth restricted baby. So it is marginal in this case, but any degree of intrauterine growth restriction is associated with a rise in perinatal mortality and morbidity. So baby F and his twin, by their nature, were high-risk babies from the very outset. Absent end diastolic flow, or ADF, goes hand in hand with intrauterine growth restriction. And what it simply means is that when the heart is resting between beats, that's called the diastole, blood ceases to flow through the placenta, when that should not otherwise be the case. Now, blood will slow down in the placenta during diastole, but it shouldn't stop. And these things are picked up on routine neonatal ultrasound scans. And if the end diastolic flow is severely compromised, it's almost certainly going to lead to an emergency cesarean section, because the metabolic demands of the growing twin are increasing all the time, but the blood flow needed to supply the energy for that growth isn't keeping up. So it is a very serious problem, and there usually isn't much choice other than section in emergency situations. So it carries on. He had mild respiratory distress syndrome and hyperglycemia requiring insulin treatment. So we can immediately see that the baby is born with problems. The mild respiratory distress syndrome means that he cannot breathe properly and he can't get enough oxygen to meet his energy requirements. And there's no guarantee that the mild respiratory distress syndrome is going to remain mild. With proper treatment, it shouldn't, but that's not guaranteed. And straight away, we also see that he has hyperglycemia, which is simply a high glucose level reading in the blood. So BBF from the off cannot control his blood glucose, and he requires insulin to bring that under control. Now, again, in the trial, the hyperglycemia was passed off as a minor problem, but it's very far from a minor problem. Hyperglycemia is associated with significant short-term and potential long-term health complications in these babies, particularly when they are low birth weight. The morbidity and the mortality rate goes up in these babies. They have higher incidence of stroke in the brain, intraventricular hemorrhage, IVH, respiratory distress syndrome, sepsis and other infections, necrotizing enterocolitis. And the hyperglycemia is basically caused by either impaired insulin secretion, so they can't make the insulin or secrete it or transport it. Or they might be resistant to insulin. In other words, even when they get insulin to the cells, it doesn't work. It requires more and more to open the cells up and allow them to take glucose into the cells to produce energy. And remember that we said before, energy isn't distributed around the body. It's used at the point where it's made. So we cannot, for instance, allow the brain or the heart to borrow energy from muscles that aren't being used. The brain and the heart have to make the energy on the spot. And if they're insulin resistant, that's going to seriously impair their ability to do that. We also know that insulin isn't always effective when given therapeutically. That's the exogenous insulin that these people talk about all the time. And as we pointed out in baby F's case, they overtreated the baby when the blood sugar went low eventually and ended up driving the blood glucose level back up to near hyperglycemic levels. On the 5th of August 2015, at 1:30 hours in the morning, he developed sepsis and hypoglycemia and was treated with antibiotics and intravenous IV glucose infusion. Over the next 17 hours, his blood glucose remained low, range 0.8 to 2.4. And remember, the bulk of them were bedside measurements, which are not going to be accurate. And this was despite repeated boluses of 10% dextrose. And at 10 o'clock in the morning, his long IV line was noticed to have tissued with extensive swelling and induration of the right groin, thigh and leg. IV fluids were stopped from 10 to 12 while a new long line was inserted, and at 12 o'clock the IV bag was changed. At 1900 hours, the dextrose infusion was increased to 15% and the hypoglycemia resolved. And as we said in our podcast, the amount of fluid that was present in the thigh of the baby was enormous and likely represented most, if not all, of the glucose given to the baby over the night of the 5th of August. And the conviction. It was alleged that baby F was given exogenous insulin through the infusion bag because there was a prolonged period of hypoglycemia. His blood glucose inexplicably rose from 1.3 to 2.4 when his dextrose infusion stopped from 10 to 12. His blood sugar rose after his infusion bag was changed at 7 o'clock that evening, and he had high insulin, low C-peptide levels, which indicated exogenous insulin was used. And the panel experts, the hypoglycemia started with sepsis and was prolonged because the IV infiltrated for several hours. That means it was tissued and wasn't going into the veins. When hypoglycemia persisted despite 10% glucose infusion, the higher glucose infusions should have been given earlier. Repeat boluses of 10% dextrose worsen hypoglycemia, and we pointed this out because it's unnatural to take on food or energy that way. And they said that these boluses cause surges of blood sugar, which trigger surges of insulin secretion, resulting in a yo-yo pattern of sharp rises and falls in insulin and blood sugar. When the dextrose infusion was stopped at 10 to 12 in the morning, the blood sugar did not rise from 1.3 to 2.4 as alleged, because the blood sugar was 1.4 at a quarter to 12. The 2.4 level was measured after 12 o'clock when the IV was restarted. Since infusion bags were prepared in the pharmacy, stored in the unit and changed at 12 o'clock, multiple infusion bags would have to be contaminated if there was insulin poisoning. The blood sugar rose after 7 o'clock in the evening, not because the infusion bag was changed, but because the dextrose was increased to 15%. And we pointed that out in our podcast, but also the fact that the line was now working again. So Jeff Chase and Helen Shannon, CNX, reported that preterm infants have different insulin and C-peptide normative standards than adults. Exogenous insulin is unlikely to be the cause of hypoglycemia because the C-peptide was not low for a preterm infant. It was, they say, within the 20th to 45th percentile. That means that between 20 or 45 babies will have that level of C-peptide measured at that age in those circumstances. Potassium levels were normal. Insulin decreases potassium. Well, not only were they normal, but they actually rose. And remember, we said in our podcast that the potassium lowering effect of insulin is independent of its effect on glucose. Because when a cell takes up glucose, it exchanges a potassium ion. So the movement of glucose and the movement of potassium, are very closely linked. But keeping potassium level in the blood is critical to the functioning of the heart. And if it goes too high or too low, it will lead to arrhythmias in the heart very, very quickly. So evolution has provided a solution by including a fail-safe system whereby the insulin will drive the potassium back into the cells quickly after the glucose has forced them out. It's a very elegant solution. And the paper carries on, glucose levels should be lower if exogenous insulin was used. The insulin C-peptide IC ratio was within the expected range for preterm infants. Insulin autoimmune antibodies, IAA, which are common in preterm infants, bind to insulin and increase measured insulin levels. And the immunoassay test is unreliable because interference factors like sepsis, antibiotics, can give false positive readings. So I would say this is just a summary, a very short summation of all of the problems related to the immunoassay. What happens with these immunoassays? They don't measure insulin directly. They measure it indirectly by measuring antibodies to insulin. And there are certain antibodies, insulin, autoimmune antibodies, IAAs, which will bind to these tests, these immunoassays, as if they were insulin. And then when you go to do the processing of measuring it, the machine thinks it is insulin and reports it as being insulin when it isn't. And it's time that we stop using these immunoassays in forensic cases because, number one, they were never designed for that purpose. Number two, they're likely not validated for that purpose, which is a legal requirement. But they are singularly useless in preterm babies because we haven't reached steady state dynamics between insulin and glucose. And indeed, in baby F's case, that was evident from the day he was born. And we will in time see a lot more work from Helen and Jeff Chase that hopefully will be groundbreaking in many ways, not just for Lucy Letby, but for other cases where these immunoassays are used forensically. So the conclusion of the panel was that BBF had prolonged hypoglycemia because of sepsis, prematurity, borderline intrauterine growth restriction, lack of intravenous glucose when the long line infiltrated for a prolonged period of time, and the poor medical management of hypoglycemia, which is really self-evident when you read the confusion between the different lines and bags that were going on during the treatment of BBF. And the report also says that BBF's insulin level and insulin C-peptide ratio do not prove that exogenous insulin was used and are within the norm for preterm infants. Preterm infants, and especially those with illness and drug treatments like antibiotics, have different normative standards compared to healthy adults and older children. And Jeff Chase and Helen Shannon have been working on a vast amount of data that actually shows this. And we still haven't got to the bottom totally of the 999 millimoles per litre, which is an impossibly high level of glucose in the blood, which happened to occur from the same sample. So we have a sample that gave us this massively high, though still acceptable for a preterm baby, reading of insulin, as well, apparently, as a very high reading for glucose in the blood. But none of this was discussed in any detail during the trial of Lucy Letby. I actually found the explanation for baby F when I was doing the podcast one of the easiest ones to understand. They were pumping the baby full of glucose, but none of the glucose was getting into the baby's system, or very little was getting into the baby's system, so they couldn't drive the glucose back up again. And when they finally cleared the line and started using 15% dextrose for a short period of time, the blood glucose rocketed up. So it will be a matter of watch this space, and hopefully Jeff and Helen will release their broadside on the nonsense told by the expert witnesses in the Letby trial. In fact, I've no doubt in due course that they'll do that. And now we move on to baby 7 summary, which is baby G. And baby G was 23 weeks, so that's on the very edge of viability. And the baby was only 535 grams at birth and was born in the bathroom, in the toilet of Harrow Park Hospital after a premature rupture of membranes, was suspected chorioamnionitis. The amnion in the chorioamnionitis, the amnion is a thin membranous structure and it encloses the fetus and the amniotic fluid, and it protects the baby in the womb from external shocks, and it facilitates the exchange of fluids from the mother and waste from the baby, as well as respiratory gases. And the chorion is the outer membrane that surrounds the amnion, and it acts as a barrier between the amnion and the mother. And its main role is to act as a barrier that provides immune protection from the mother, because remember, the baby is an individual distinct from the mother, and therefore theoretically can induce an immune response to the mother. But the chorion protects the fetus and prevents it from doing that. And it also plays a big part in the endocrine function of the fetus during pregnancy. And chorioamnionitis is simply an infection of these multiple layers that are protecting the baby and providing all the function that allows it to grow. So we can see that infection of this structure is a deadly threat to these babies. And the report carries on that the baby was resuscitated at birth and treated for severe membrane hyaline disease, which is another term, an older fashioned term for respiratory distress syndrome. And respiratory distress syndrome is basically the absence of a material called surfactant, which allows the airways to open up and remain open while the gases exchange. She also had bilateral pulmonary interstitial emphysema. Pulmonary emphysema or interstitial emphysema, interstitial just means between organs. Just think of it as that, anything that separates one organ from another, or even components of an organ from one another. And pulmonary interstitial emphysema, or PIE, is a condition where the air leaks out of the normal air spaces, that's in the little alveoli, and in the larger branches of the lung carrying the air to the alveoli, and it leaks into surrounding tissues in the interstitium. And it usually happens at preterm babies who need mechanical ventilation because of the lung immaturity and other diseases like respiratory distress syndrome. And ultimately, it can lead to a collapse of the lung and respiratory failure. It is a deadly condition to have. The baby also had hyperglycemia, so high blood sugar, again, not able to control the energy flow around the body. It had anemia, therefore not able to carry enough oxygen around the body. And it had thrombocytopenia, which means a low platelet count, therefore can't control clotting around the body. She had a patent ductus arteriosus. Now, the ductus arteriosus is a normal blood vessel that connects two major arteries, the aorta and the pulmonary artery, that carry blood away from the heart in utero. And that's because the baby's lungs don't work while it's in utero, because it gets its oxygen directly from the mother via the placenta. But when the baby is born, These two major arteries, pulmonary artery, which carries deoxygenated blood from the right side of the heart to the lungs, and the aorta, which carries oxygenated blood from the heart, the left side of the heart, to the rest of the body. It's necessary, therefore, that this ductus arteriosus closes off once the baby's born, because you have to separate those two parts of the circulation, the lung part and the rest of the body part, so that you can keep oxygenated blood separate from deoxygenated blood. But when that remains open or patent, we get all sorts of problems. Blood starts to flow from the aorta into the pulmonary artery, and that increases the blood flow to the lungs. And that leads to congestion and strain on the heart. And it also deprives the rest of the body of that portion of the oxygenated blood that's simply going around in a circle being reoxygenated again. These two major components of the circulation should be separate, and in this baby, they weren't. And the baby also had mild bilateral dilatation of the cerebral ventricles. Mild speaks for itself. Bilateral just means on both sides. And ventricles in the brain are a system of interconnected cavities, essentially spaces within the brain, and they make and circulate cerebrospinal fluid. And there's four main ventricles. There's the lateral ventricles, third ventricle, and the fourth ventricle. So they make this cerebrospinal fluid, which acts as a shock absorber and protects the brain from injury, and it causes the brain to float upwards, which takes pressure off the brain stem. And the brain stem is the part of the brain that controls the vegetative functions of the brain. So these are the bits that make the lungs breathe and the heart beat without you having to think about it. And if you didn't have that buoyancy and the brain is pushed down towards the cervical spine, that's called coning, C-O-N-I-N-G, and disrupts the function of the brain stem. And it can actually cause death. It happens in head injuries, etc. And the cerebrospinal fluid needs to move around these ventricles easily, because that is the basis of maintaining all the chemical activity of the brain. So we can see here that baby G was a very, very sick little baby. And she was transferred to the Countess of Chester Hospital at 34 weeks. So she stayed in Arrow Park for over 10 weeks. And she was on Optiflow, a type of nasal CPAP, when she was transferred. And she also had gastroesophageal reflux, which just basically means that the stomach would empty upwards as well as downwards. At 38 weeks, she had a sudden projectile vomit, large watery stools and desaturation, followed by apnea 2 hours later. The abdomen was described as purple and distended. She was bagged and intubated with a size 3 endotracheal tube, and blood-stained fluid was noted coming up the trachea. She was ventilated, sedated, and given antibiotics. Chest x-rays showed patchy consolidation consistent with chronic lung disease, which is just, you could think of it as a chronic or long-term version of respiratory distress syndrome, meaning that the baby never fully recovered from the respiratory distress syndrome that was present at 23 weeks. So again, it's a sign of profound illness in the child. Her CRP, or C-reactive protein, and white cell counts were unremarkable. She stabilised and was transferred to Arrow Park Hospital, where she was ventilated for 6 days and given antibiotics for CRP rising to 218, which is a massive rise and clearly indicates that the baby had a very active infection. Blood, urine and CSF, cerebrospinal fluid, and respiratory cultures were negative, and she returned to the Countess of Chester Hospital and was discharged home. And the conviction, it was alleged that baby G was deliberately overfed and had the air injected into her stomach through the nasogastric tube, causing the vomiting and clinical deterioration. Now, we have to remember at this point that Dowie Evans has since withdrawn all of that nonsense because it never had any evidential basis in clinical practice or pathology. It was a condition that he invented. And the panel conclusion was that baby G had infection on the night she vomited because she clinically deteriorated and desaturated and had apnea and had C-reactive protein rising to 218 over the next days, which are all signs of infection. It is not uncommon for CRP to climb after onset of clinical signs when there is infection. She had vomiting and large watery stools, which are common in the enterovirus infection and will explain why the blood, urine, cerebrospinal fluid and respiratory cultures were negative for bacteria while the CRP was high at Arrow Park Hospital. Large watery stools are not consistent with overfeeding. Abdominal distension and discoloration over the abdomen are common when infants are ill with ileus, and that just means a paralyzed small intestine, which can be temporary. And they usually disappear, these discolorations, when the baby is recovered. The abdominal x-rays showing gaseous distension of the intestines were all taken after bag and mask ventilation and are consistent with air introduced by bagging and ileus in a sick infant. The blood-stained fluid coming up the trachea was most likely caused by the intubation. Chest x-ray post-intubation did not show any continuous consolidation suggestive of pneumonia or pulmonary hemorrhage. She received 7 days of antibiotics and recovered after 7 days, which is consistent with enterovirus infection since it is usually a self-limiting disease. And the conclusion, baby G had vomiting and clinical deterioration due to infection, possibly enterovirus. There is no evidence to support air injection into the stomach or overfeeding, and there never was. This is the way that people normally practice medicine, based on the principle that common things occur commonly. Baby G was a very vulnerable baby for multiple reasons, and she was being cared for in a shithole, literally a shithole. I would say that it was inevitable that the baby was going to get some kind of infection, and enterovirus is a very likely infection that you would get because enteroviruses live in shit. So it begs the question why a so-called expert like Dowie Evans would invent causes of harm to a baby that he would later have to withdraw, when it's so obvious with the runny green stools that the baby had gastroenteritis. All of the clinical findings for baby G are everyday common events, and the clinical course that baby G ran, 7 days on antibiotics, 7 days resolution of the symptoms, are what you would expect. Yet, within this scenario, Dowie Evans finds attempted murder. And we are insane as a society if we allow this to stand. Now we get to baby 9, which I think is baby I. Baby I was a 27-week, 970-gram birth weight female infant with intrauterine growth restriction who was born after premature rupture of membranes at Liverpool Women's Hospital. She was treated for mild respiratory distress syndrome with respiratory support and antibiotics for sepsis beginning on day 1 of life, and with intravenous and enteral feeds by oral tubing. She developed bradycardias, respiratory distress, and an elevated white cell count, leading to her first of 5 transfers to 4 hospitals on day 12 of life. She developed chronic lung disease, abdominal distension, and recurrent episodes of apnea, desaturation, and bradycardia, requiring resuscitation and ventilation. She had viscous, gelatinous secretions from her airways and mouth that were associated with frequent blockages of her endotracheal tube, and sticky stools. A registrar stated that it's not unusual for babies on breathing support to get secretions but it was a bit unusual for them to be so stubborn at being removed. Testing for cystic fibrosis was sent. She had an episode of lung collapse at 2.5 months, and she had an episode of severe apnea, bradycardia, desaturation, and heart block, and the baby died. The conviction was that it was alleged that air was injected into baby I's stomach via a nasogastric tube, leading to recurrent episodes of abdominal distension, splinting of the diaphragm, and respiratory arrest. On the 13th of the 10th, 2015, it was alleged that the apnea alarm was deliberately turned off, resulting in delay in response to a collapse. On the 15th of the 10th, 2015, it was alleged that air was injected into her intravenous tubing, causing air embolism and death. And the panel's opinion: baby I was a very premature intrauterine growth-restricted infant with respiratory distress syndrome and chronic lung disease. Stentorphomonas multifida bacteria was detected in surveillance cultures from her endotracheal tube. S. multifida is a multi-resistant, opportunistic pathogen that can colonize the airways in biofilms. They are resistant to antibiotics and generally impossible to clear in patients with chronic lung disease. And this is a truly astonishing finding, because not only do we have one biofilm creating bacteria, Pseudomonas, we now have another one. And it was detected as part of surveillance. How in the hell did anyone miss this? And what other surveillance have they missed? It carries on. The thick secretions can block ATTs and interfere with ventilation in the small airways of these vulnerable infants, which together with other factors like chronic lung disease lead to recurrent episodes of apnea, desaturation, bradycardia, respiratory failure, and collapse. And that is the sequence that the deterioration of these babies takes, depicted by the so-called experts as unusual, unexplained, and unexpected. But if you're not going to pay attention to the surveillance that you're doing on pathogens in your ward, of course you're going to suffer unexplained and unexpected events, which will take this pattern: apnea, desaturation, bradycardia, respiratory failure, and finally collapse. S. multifida colonization would have further compromised her ventilatory capacity. The initial abdominal distension was likely due to sepsis causing ileus and to lactose intolerance, as there was a family history and stools were positive for reducing substances. So what that means, a stool positive for reducing substances in the context of lactose intolerance, is a suggestion, a very strong suggestion, that the baby has lactose intolerance. And lactose intolerance simply means that the baby cannot digest lactose. Any compound with OSE at the end of it, glucose, fructose, lactose, are all types of sugar. Lactose is the sugar in milk, hence the name, and it is what's called a disaccharide. So it's made up of two different sugars, one of them glucose and the other one galactose. Now there is an enzyme called lactase, ASE, and anything with ASE at the end of it is an enzyme that breaks down something. So lactase is the enzyme that breaks down lactose. If it's absent and the lactose isn't broken down, the small intestine doesn't absorb it. And that is the job of the small intestine. Instead, the sugar then passes into the large intestine, undigested, and undergoes fermentation by bacteria that live in the large intestine. And that produces lactic acid and other substances as part of the fermentation. But because the fermentation isn't complete, lactose, glucose, and galactose escape in the stool, and those are the reducing substances that you pick up. Along with the family history, this would really point towards lactose intolerance, but it wouldn't be definitive of it. You can do another test called a hydrogen breath test to add to the possibility of your diagnosis. But again, this is a very bad thing to miss in clinical practice. Why are you doing these tests if you're not paying any attention to them? And the report goes on, the repeated abdominal x-rays showing intestinal gaseous distension were all taken after resuscitation, and error was likely introduced by bagging, a recurrent and repeated theme in all of these cases, and a very simple, straightforward explanation. A nurse explained that the reason the apnea alarm did not sound was because the apnea alarm goes off if there is a 20-second period of no breaths, but because there was gasping and it was less than 20 seconds, it hadn't gone off. There is no evidence of our embolism, and baby I was not treated for S. multifida. Unbelievable. And this is, of course, far more information than I had from the public record when I was dealing with the case of baby I. And the conclusion, baby I died of respiratory complications caused by respiratory distress syndrome and chronic lung disease, complicated by S. multifida colonization. The doctors failed to respond to surveillance warning about S. multifida, did not recognize the diagnosis, and did not treat her with the appropriate antibiotics. This was a likely preventable death. So how horrible is that for the parents to hear? That is the very definition of suboptimal. You have the information that you looked for. You witnessed the consequences of the information that you had, and you totally ignored it. And as a consequence, the baby likely died. There is no evidence of error causing splinting of the diaphragm or of our embolism. There is evidence that the apnea alarm was not turned off. Where does Dowie Evans go now? Is he going to tell us that a second biofilm-forming bacteria that is multi-drug resistant and was colonized during the surveillance of baby I isn't relevant, but that his half-cocked theory of injecting babies with air to cause splinting of the diaphragm, which he has since abandoned as a cause of death, is more relevant? And don't forget, Dowie Evans has already called out these experienced people who are doing due diligence when reading the files as being wrong. How are they wrong? At this point in time, or after this press conference, is there really anyone left who believes that Lucy Letby is guilty? And I mean even in Operation Hummingbird and among the other expert witnesses who were compartmentalized when they were giving their evidence and who relied, to some extent anyway, on the proper analysis of the files by Dowie Evans and Sandy Bowen before they gave their evidence under oath. Next we get to BBK. And remember, these are all summaries. BBK was a 25-week, 692-gram female infant who was born by footling breech. That wasn't mentioned in the trial. A footling breech is a type of breech birth, that is when the feet come first. And that can be one or two of the feet. And it's a high-risk delivery because the foot or the umbilical cord can slip through the cervix before the rest of the body, causing the head and shoulders to become trapped. And it's very heavily associated with birth asphyxia and trauma, and sometimes even an emergency cesarean section before the foot has descended too much. At birth, she was dusky, floppy, and a low heart rate, 60 per minute, and no spontaneous respirations. She was resuscitated with bagging and intubated after 3 attempts with a size 2 endotracheal tube. Blood-stained secretions were noted. She was mechanically ventilated and a large air leak of 94% was noted. Her blood gases showed respiratory and metabolic acidosis. 1.5 hours later, she desaturated, A consultant bagged her with neopuff, but there was no chest movements. The capnograph test was negative for carbon dioxide, and the capnograph is just a machine at the expiratory end of the ventilator that measures the presence of carbon dioxide. And if there's no carbon dioxide coming out, there's no oxygen going in. He reintubated the baby with a size 2.5 ATT. And we talked about this in another podcast. The dangers of using a 2mm tube. Re-established chest movements and stabilized the infant. Chest x-rays were consistent with respiratory distress or pneumonia. There were 2 further episodes of desaturation requiring resuscitation. Baby K was transferred to Alderhay Hospital. Conviction. The consultant alleged that Baby K's first episode of clinical deterioration was caused by deliberate dislodgement of her endotracheal tube, since bagging failed to move the chest and carbon dioxide was not detected by capnograph. He alleged that the incubator alarms were deliberately turned off to prevent prompt rescue response because he did not hear the alarms when he entered the room. And the panel opinion, Baby K required a 2.5mm ATT. Instead, she was traumatically intubated with a size 2 ATT with the resulting 94% air leak. As a result, ventilation was ineffective because 94% of the air was leaking out and only 6% was entering the lung. Effective gas exchange could not occur, and mechanical ventilation could not generate sufficient pressure to keep the small air spaces in the lungs open. This led to gradual collapse of the small air spaces in the lungs and deteriorating gas exchange. When the tipping point was reached, the infant decompensated, desaturated, and collapsed. Bagging to reopen the collapsed small airway spaces in the lungs required relatively high pressures. With a 94% air leak, bagging with the neopuff, which has a safety feature to limit air pressure, did not generate sufficient pressure to move the chest. Capnography did not work because the device measures build-up of carbon dioxide in the endotracheal tube during expiration, but with a 94% air leak, the carbon dioxide could not build up sufficiently to trigger the measurement. There is no evidence to support dislodgement of the endotracheal tube. The consultant stated that he did not hear the alarm, but a nurse, not Lucy Letby, stated that, "When I returned to the unit, I immediately became aware of the alarm sounding from Baby K's incubator." The conclusion: there is no evidence to support a dislodged endotracheal tube. The clinical deterioration was caused by use of an undersized endotracheal tube. The initial intubation was traumatic and poorly supervised. The consultant did not understand the basics of resuscitation, air leak, mechanical ventilation, and how equipment that were commonly used in the unit worked. Example, neopuff and capnograph. There is evidence that the incubator alarms were not turned off. And this is damning, hellishly damning, for the man who said that this would live in his nightmares forever. How prophetic. And finally, we get to Baby O. That's Baby 15 summary here. Baby 15, or Baby O, was a second triplet born at 33 weeks by in-labour caesarean section at the Countess of Chester Hospital. Now, there is another piece of information that we didn't have, that this section was in labour. It was not an elective section. It was likely a frenetic emergency section. He weighed 2.02 kilograms. He had mild respiratory distress requiring continuous positive airway pressure and oxygen. The triplets were extracted at caesarean section very quickly, a minute apart. And that would be consistent with the in labour caesarean section. Although triplets are very often delivered quickly, they're always delivered carefully. So I think that the in labour part does add more information to what happened. BBO's hemoglobin on the day of birth, day 1, was 168 grams per litre, and that would be 16.8 grams per decilitre. The next day, day 2, he was changed to Optiflow and started on small amounts of feeds. At 36 hours, he was noted to have a rising heart rate and respiratory rate, temperature instability, and mild abdominal distension. And these are truly disastrous findings. He did not pass meconium until 32 hours of age. Meconium is usually passed within the first 24 hours, and meconium simply refers to the first stool that a newborn passes. The next morning, day 3, his abdomen was more distended with visible loops of bowels, and he was uncomfortable after a feed. By afternoon, he vomited undigested milk and had high blood lactate 5.4 and carbon dioxide 7.09, bilirubin 156, and acidosis pH 7.2. Disastrous. He was given fluids and antibiotics. At 1400 hours, he developed a profound desaturation and low heart rate, 80 to 90 per minute, and looked mottled. A small purpuric discoloration was transiently seen on the right chest during the resuscitation. At 1551, he desaturated again and was reintubated, receiving cardiac massage, adrenaline, 8 doses, bicarbonate, 3 doses, and saline infusions. His ventilation pressures were increased to 32/6. Sweet Jesus. So these measurements are in centimeters of water pressure. Typical ventilator pressure for a baby, a preterm baby, would be between 5 and 8 centimeters of water, and maybe up to 15 for very short periods of time. But nowadays, not more than that, because the pressure is so destructive to the lungs. And he was intubated and ventilated on 28 centimeters of water. Earlier on, dopamine was started and needle aspirations of the abdomen were performed. An intraosseous, that's a line into the bone, was inserted because of poor circulation. At 1743, blood gas showed marked acidosis 7.01 and a hemoglobin level that had halved. No heart rate was heard. At 1747, resuscitation was stopped after consultation with parents. Postmortem showed a ruptured subcapsular hematoma of the liver. Conviction: it was initially alleged that baby O received inflicted blunt trauma to the abdomen, causing purpuric discoloration and a ruptured subcapsular hematoma of the liver, and that air was injected into the nasogastric tube to cause gaseous distension of the intestines. Later, that accusation was changed to deliberate injection of air into his circulation. Panel opinion: BBO collapsed because the subcapsular hematoma ruptured, causing acute major hemorrhage into the peritoneal cavity, sufficient to cause a near halving of the hemoglobin level. Subcapsular liver hematoma is the result of traction or shear forces applied to the thin, fragile liver capsule through the hepatic ligaments. In BBO, this was highly likely the result of an extremely rapid delivery, which is a well-recognized cause of birth injury. Bleeding into a subcapsular hematoma is characteristically initially slow because it is contained by the pressure of the enveloping liver capsule. In these early stages, the clinical signs are insidious and difficult to recognize. High-pressure ventilation decreases venous return to the heart and contributed to the liver congestion. So, because of the high pressure, the blood can't return to the right side of the heart, and it starts backing up behind the pulmonary artery. And one of the places where it's going to back up most is in the liver, because the liver has such a massive amount of blood flowing through it. And this congestion is going to put the liver under pressure internally within the capsule, meaning that when the subcapsular hematoma eventually does erupt, it's going to explosively erupt. The slow deterioration is then characteristically followed by acute collapse, the report goes on, when the capsule ruptures, releasing free blood into the peritoneal cavity. The significance of the rising heart rate and falling pH before the terminal collapse were not recognized. The blind abdominal insertion of a needle during resuscitation may have penetrated the right lobe of the liver, causing further injury noted by the pathologist as parenchymal hematoma and laceration. So therefore, the original pathologist identified not only subcapsular hematoma, which is a distinct entity, but also parenchymal hematoma, which is a hematoma within the tissues, connective tissue of the liver. And he also noted laceration. Blunt, direct trauma to the right abdomen or chest is implausible because it is very difficult to generate the kind of force required to produce the observed injuries in a liver protected by the lower chest wall. The gaseous distension of the intestinal tract was likely due to air swallowing and insufflation during non-invasive respiratory support. The suggestion of injection of air into the circulation is conjecture. And the conclusion, PBO died from a subcapsular liver hematoma caused by traumatic delivery resulting in hemorrhage into the peritoneal cavity and profound shock. This was not recognized ante-mortem. And I think that's a very kind summation. There are so many things wrong in this description, and it's baffling why none of this came out at the trial, particularly the findings of the post-mortem. Now, people can and will argue that this is just opinion, but it's not just opinion. It's fact. We have pathogens. We have explosive pressures. We have acidosis. We have post-mortem findings. And we have chains of evidence that link together to explain what happened to the babies. This is not opinion. This is the medical interpretation of a causal chain. And it's likely that 99.9999% of doctors practicing in the world would follow the same causal chain. The exception would be Dowie Evans, who, as far as I'm concerned, has nowhere left to run. So we'll finish this now, and we'll finish the entire report in the next episode. So damning stuff as far as I'm concerned, and we'll see you in the next episode. Bye.